A warm good afternoon to the august audience, my dear colleagues, my PGs and fellows. Christy and Manavi was little lucky because they had a focus topic. Mine is a very broad topic. So I have to give an overview of all the pediatric orbital diseases. So I have chosen few conditions which is common, and I intend to focus little uncommon presentations of those common conditions, which is useful for general ophthalmologist. And tomorrow when you will be going to practice in your places, be it a GH or a medical college or even in your private practice, I think this presentation should be useful to you. I thank Veena ma'am and Frederick sir for this wonderful opportunity, because PASS is something which is very close to my heart. So first of it, when you think of pediatric orbital conditions, you think of ptosis. So we see it day in and day out. So I need the PGs to interact with me. I don't want a dozy session. So you all see this day in and day out, right? This is a simple congenital ptosis. So can one of you name the classical sign? No, I don't want a special condition, the sign. So you have a faint or an absent lid crease. Yes. So the Marcus gun. So simple ptosis with a Marcus gun. What is the advantage of Marcus gun? You may be amazed by what is this she's saying, advantage of Marcus gun? What is the main thing that you're scared of in a ptosis apart from your cosmetic appearance? Yes. So Marcus gun, the child doesn't have an amblyopia, because the brain knows that when the child opens her mouth or his mouth, or when it, you can always see that when the child is brought to you by the parents, it always has an open appearance. The child never closes his or her mouth. So that is one advantage, because the child never goes for amblyopia. So I'm little happy when I have a Marcus gun geometry. So next we have a complicated ptosis. What is so complicated about this? Can somebody tell me explain about this? How is the appearance? So it's a pediatric conference. So you have a hypotropia. So the dictum is, where the eye goes, the lid follows. So when your eye is orthotropic, the lid also will be in the correct position. When the eye is hypotropic, the lid obviously will be in a grouped position. So when you have to assess, you have to cover the normal eye, apparently normal eye, and bring this hypotropic eye to the fixing position and see whether still the ptosis is present. And second thing is, or any ptosis correction is associated with a poor bells, and we warn the parents about the post-op lag of thalamus. So when there is a hypotropia, definitely the bells is going to be poor. So the dictum is, first squint correction if need be, if the eye is hypotropic, or if the eye is not hypotropic but still it is elevation is only restricted, again we will have to get opinion of a pediatric ophthalmologist to make before attempting a sling correction. And a sling correction in all these cases will be little under correction. And the family on to the right. So when I say a family, it means autosomal dominant. So you can see father with his two daughters. So the classical condition of blepharophimosis, so it encompasses 8 pathologies, the main ones being blepharophimosis, epicanthus inversus, so vertical ptosis, and also a narrowed palpebral fissure with a telecanthus. So another one, a very rare condition that we encounter, often referred to as ptosis. So whenever a child is referred to you as ptosis, pay an attention first to how the eye alignment is, and then you will get a clue based on that. So here you can see her only abduction is reserved. So the treatment, everybody knows that frontalis sling is the choice of surgery, because the LPS action is invariably poor because of a dysgenetic muscle. There can be LPS resection done in few cases where the LPS action is a better, little better. A sling with elevated disinsertion is done classically for PGs. I want you to answer. Nishant? Anybody? Madam, you're an expert. So undercorrected sling, as I said, it is for elevated restriction without hypotropia. If there is a hypotropia, vertical squint correction first, followed by a undercorrected sling. Observation only for those cases when the visual axis is clear, when the parents are willing to come for a regular follow-up, because it is not only ptosis that we are correcting. We have to monitor refraction and amblyopia. So there must be at least a 3 to 6 month follow-up. If the parents are educated, if you're convinced that they will be coming for a regular follow-up, then you can observe the child. Yes, only if the visual axis is clear. So the next, it is why I took up these is it is extremely uncommon to have a congenital entropion, because upper lid entropion is almost always spastic even in adults. And congenital entropion, if missed, it can lead to corneal ulcers. So it is very important to pick this up. And the masquerading condition will be epiblepharon. You can see that there is a fold of skin extend just below the ciliary line, and it is aggravated when the child is looking down. So these children will have the touch of lashes only in downward position. They will be very comfortable. They will hardly have watering, or sometimes they will have rubbing, especially in the early mornings. Unlike entropion, the child will have constant watering and photophobia. So this condition has to be differentiated from entropion. So the classical, by just seeing the face of this child, we can say that this child has got Down syndrome. So floppy eyelid is characteristically seen in children with syndromes, especially Down syndrome, where you have a congenital eversion of the upper lid on attempted closure, and also, so you can see all 4 lids are going for ectropium. And this is also one of the condition where you will have a congenital ectropion. So unlike an entropion, which has to be managed surgically, ectropion is one condition where we do not want to do any surgery. The management is essentially medical. Lot of lubricants to the children and tackling the skin with the help of dermatologists, especially with virgin coconut oil or almond oil, will do magic. One another condition, blepharochalasis. So we see old patients with all this puffy appearance. That is dermatochalasis. The easy way to remember is B comes before D. So B comes for an younger age, D comes for an older age. So you see all this puffy appearance. It may or may not be associated with inflammation. In the Indian population, in the Western literature, they say that it is quiescent. But in the Indian children, we see there can be a lot of inflammation, which has to be tackled with short course of one steroids, and it is bound for recurrence. It is a disease of unknown etiology. The only worrisome thing is that the skin becomes like a cigarette paper like appearance and lengthens and thins out when the child becomes 20-25 years of age. At that age, you will have to do a ptosis correction. If a ptosis correction is done prematurely at this stage, then what will happen, because this disease is known to recur, they will have prolonged thinning of the skin. So we can't do surgery again and again. So it is preferable to do a blepharoplasty or a plus or minus ptosis correction, at least when the person is above 20 years. And another rare condition, just a band of skin between the 2 eyelids. It just needs a scissors and forceps and as IV sedation to cut that so that the child can see better. Euroblepharon, very common cosmetic appearance in young adults. Nothing, because you have to reassure if they are still not convinced. A small cosmetic tarsorrhaphy like blepharoplasty would do. And one of the most common conditions. So essential management is Krigler's massage, because we know that 10% of the children are born with CNLDO, and of which only 6% present to us because it automatically resolves when the child is 1 month old. So whatever we see is that only 6%. So you have to refrain from prescribing topical antibiotics to all the children with purulent unless the discharge is purulent. And probing, though there are several schools of thought, because Krigler massage works magic, it is better to avoid probing till 1 year of age. And of late, because we have the endoscope, ENT persons are there. So even if bilateral cases are there, it's easier to do a probing and give a very good result, even if there is a recurrent acute attacks. And probing can be done even with older children because we are able to see the probe in the nasal cavity. So we have typically the bicanalicular stents are preferable in probing. We have the Rittling stent, the Crawford stent with its hooks, the Kaneka stent, and even the monocanalicular stent, that is the mini monoca stent, can be used for intubation. The next common condition would be capillary hemangioma. We can, this presentation, the bright red lesion is classical, whereas the child presenting like this with a small nodule masquerading as a chalazion, which you will be able to identify only when you evert the upper lid and see a bright red lesion on the palpebral conjunctiva. So this child has a lid, this has an orbital plus lid lesion, this has a lid, and this has a isolated conjunctival. You can see a stooge bubble like strawberry nevus, and then another isolated lesion. So this can be the spectrum of capillary hemangioma, and all we need to do is I observe till the child is 1 year unless it is amblyogenic. This child, as we can see, has a bright red lesion with both an orbital and a superficial component. And for the orbital component, the pediatrician gave oral propranolol, but it regressed, and the parent was not very happy with the reddish hue, for which we gave a timolol gel. That is the newer modality of treatment. It is very cheap. It is easily available in the market. Once a day timolol to be applied over the reddish lesion. The drug has to be put over the mother's finger and rubbed onto the skin. So for the superficial varieties, we need not even put the child on oral propranolol. Only for the deeper lesions or the amblyogenic lesions, we need to refer the child to pediatrician. If the lesions are small, it is not visually obscuring, then we can just do off with a topical management. Another common condition where the parents will be very apprehensive, the classical appearance on CT will have a air-like shadow. So we often tell the parents that the surgery can be delayed till the child is little older to give a general anesthesia. Then we move on to infections. The spectrum of infections would be a preseptal cellulitis, an orbital cellulitis with an abscess, or a subperiosteal abscess, or an isolated lid abscess. So how do we differentiate between a orbital abscess and a subperiosteal abscess? So the orbital abscess will have a classical ring appearance, which we studied in our general surgery. Whereas a subperiosteal, we can see that sharp angled shadow of periosteum being lifted. And subperiosteal abscess are almost always in the medial space, because the abscess spread in children, the abscess is most often due to ethmoid infection. So it breaches the lamina papyracea and the infection spreads to the lifts of the periosteum of the medial orbit. So the main difference between the management of these two would be you have to drain an orbital abscess, but subperiosteal abscess you can observe for a few days after giving IV antibiotics. So the next very interesting condition where most of the ophthalmologists miss is that they treat the conjunctivitis part with antibiotics, whereas they miss this small pearly nodule on the lower lid, which is actually the culprit. The viral follicles are in the lid and they release the particles. So the conjunctivitis is not going to heal unless you extirpate the small lesion, and then you can treat the conjunctivitis. Idiopathic orbital inflammatory disease, another interesting inflammation, classical S-shaped lid that involves the dacryoadenitis. So even with 1 or 2 doses of IV steroids, the swelling decreases. Whereas in this case, you can see that the girl has some swelling more than the lacrimal gland swelling. So her full upper orbit is involved. So this is a IgG4 disease, is a sub concept of IOID, where there is a dense lymphoplasmacytic infiltrate and elevated levels of serum IgG4. Imaging is highly recommended because it is mostly systemically involving, especially lungs. And this is recurrent when we treat it with steroids, just like IOID. It needs systemic treatment like rituximab, methotrexate. So a referral to a rheumatologist is mandatory. The only way to diagnose this is by a biopsy, and we should have a high index of suspicion to differentiate between the normal dacryoadenitis and IgG4 disease. So we have to suspect the criteria are that we have an enlargement of lacrimal gland, masses in the various ophthalmic tissues, and histopathology shows a germinal center filled with IgG4 plasmacyte, and blood test shows an elevated IgG4. We have seen lot of anophthalmos, but when we see an anophthalmos with cyst, that cyst has to be removed because if the cyst is just aspirated, it keeps on growing. So the cyst has to be marsupialized and removed fully, and then early placement of conformer and custom fit processes. So it is our duty to refer the child to an ocularist so that the child gets a good cosmetic appearance, because early placement of processes helps in the development of the cheekbones also. Then coming to the next genre, that is trauma. It can be a simple lid tear with plus or minus a canalicular tear or an orbital trauma. So I will skip the video for want of time. I want to stress on this fracture for benefit of postgraduates. You can see that there is no telltale sign of trauma in this child. The only sign is that the elevation is restricted. These are two gross, you can identify that both are fractures, but one, it is a big fracture. The whole orbit is herniating into the maxillary sinus. Whereas here, hardly there is a small fracture, like we have a green stick fracture in the long bones. So you can see that through that, the inferior rectus muscle has herniated and got trapped. So I'm more worried about the small fracture rather than the big fracture, because big fracture, they will present with enophthalmos, whereas the small fracture, they will present like this, nausea, vomiting, and a bradycardia. So we think whether the child has fallen down, history of trauma, whether they have something subdural hemorrhage or a white-eyed fracture. We should rule out a white-eyed fracture before referring to the neurologist, saying that the child has something bad with his brain. So the treatment is early repair is mandated in white-eyed fracture, where we need to release the intract muscle. Previously, all these grafts, porous polyethylene sheet and polydioxone sheets were being used. Nowadays, we get titanium plates and screws, which can be customized also, and we have osteo mesh. So the repair has become very easy. And often if there is a big fracture, the surgery has to be combined with a maxillofacial surgeon who will fix the zygoma through a Caldwell approach, and we can do the surgery through a conjunctival approach. This is a small video of fracture repair where osteo mesh is being used. After release of all the entrapped contents, a small template is used just to size our implant. And we cut the osteomesh based on the same size. Usually it is like a guitar pick. So the posterior part is narrow and the anterior part is broad. And a negative FDT shows that we have released the entrapped contents. and it is sutured. So there's no scarring when we do it through the phonics. So retrobulbar hemorrhage, even children, they will not be able to tell, they'll just cry. So only sign what we have is, apart from proptosis, is RAPD. There is no harm in giving a shot of steroid. So immediately give a shot of steroid and then palpate the globe. If it is tense and tight, you can do a small canthotomy under IV sedation, which will save the sight of the child. Rhabdomyosarcoma, we are not the sight savers, but we are life savers, because the child is brought to us because the parents think that is something wrong with the eye. And rhabdomyosarcoma, unlike other cancers, it is very fast growing. It grows within days to weeks. So the typical history is very petty, like the child fell down or he had an URI, something like that. Whereas this size is achieved within 10 days to 15 days. So it is mandatory that you refer the child to an oncologist immediately. So hardly subtle swelling on the supraorbital area, and you can see how big the mass is. The next is very interesting, venolymphatic malformation. So it is a spectrum among the hemangioma. So capillary, cavernous, and venolymphatic. Slow flow. Previously it was called venous malformation. Now they are calling us venolymphatic malformation. The typical history will be it enlarges with URI in a child. So children have more episodes of upper respiratory infections, and during an upper respiratory infections, because there are lymph vessels, it reacts. So the proptosis increases, and then after that it becomes to the original size. So when brilliantly enhancing with contrast, you can see that only some vague mass was there, but after contrast, it is enhancing brilliantly. So the new drug is bleomycin. It is actually an anti-cancer drug. But previously, before this bleomycin came into vogue, we did not have much of an option because we can't excise the mass. It will bleed. It is a venolymphatic. So we had just had to debulk. Now, we can inject bleomycin into the orbit. Like if we aspirate 5 ml of that fluid, we can inject 1 ml. It causes, inhibits DNA and ultimately causes scarring and fibrosis of the cyst, and then it reduces, that's how it reduces the proptosis. So in summary, in ptosis cases, we have to watch out for amblyopia and refractive errors from 6 months onwards, because before that, assessment of a child is very difficult. The child has to sit on mother's lap for us to assess the ptosis. Then imaging is a must. If orbital cellulitis doesn't respond in 24 hours, is to watch out for abscess. Steroids do play a role in orbital cellulitis, unlike other systemic infections. When trauma is in the middle 1/3 of eyelid, think of canalicular trauma unless proven otherwise. Always do a slit lamp examination. It might appear just like an abrasion, just medial to the punctum, but do a slit lamp examination to prove that there is no canalicular trauma. And fractures do present with systemic symptoms. Beware of white-eyed fracture. Simple canthotomy, it's sight-saving in retrobulbar hemorrhage. And we are also lifesavers due to early referral to the oncologist. Thank you for patient listening.